سامعك.
تمام. تمام، احنا دلوقتي لايف. بس كده على الجروب، شوف كده الدنيا عاملة ايه. تمام. We are live now, دكتور أحمد.
اوكي. Good evening, دكتور.
Good evening, دكتور أحمد.
Good evening, دكتور عبد الرحمن. How are you?
Fine, I'm fine, دكتور أحمد. Hello, our members. Let's join us here. Okay. Let's wait a minute for our audience, Dr. Ahmed, please.
Okay.
36 viewers. Good. Okay, let's share the post in my page. Share now.
Okay, Dr. عبد الرحمن, still now, we can start now.
Yeah. Okay. I'm sharing the link of the video. Okay, let's start, Dr. Ahmed. Let's start. Okay, hello everyone. I'm Dr. Abdurrahman Al-Khouli. I'm Assistant Lecturer of Endodontics Department of Endodontics, Faculty of Dentistry, South Carolina University in Egypt. I'm also Silver member in the Excellence Endodontics Facebook group. Welcome to our conference, the 6th online conference with amazing lectures. Here in our group, Excellence Endodontics, we are about reaching 100,000 members. It's a great honor for us for having this number of members. Here we are in the 6th online conference of the Excellence Endodontics Facebook group. We have a lot of great speakers all over the world, and one of them is Dr. Ahmed Youssef, our speaker today. We would like firstly to thank our sponsors, the platinum sponsor, Zaor company, and this is their promo video. Thanks, Zark. I would like also to thank our golden sponsor, the Enjoy Company, and this is their promo video. Okay, thanks, Denjoy. Would like also to thank our silver sponsors, Coxo Company and Dexys. Our bronze sponsors, Ramo Medical and AT. Thank you very much for sponsoring this conference. Please interact, share the live link, invite your friends and colleagues to join in the group so everyone can benefit from the conference. Do not forget to fill the Google form to win 8 excellent prizes: Endomotors, obturation systems, Apex locators, rotary files, and other good devices. Take care. Okay, you can win 8 prizes, at least Endo rotary motors, Endo obturation systems, 100 rotary kits, and other prizes by attending the live webinars, interacting, and doing the following. Number 1, join the Excellence Endodontics group via this link. Number 2, invite at least 3 new colleagues, dentists, students, assistants, or who belongs to the dental field to join the Excellence in Endodontics group. Number 3, write your name, your Facebook account name, and the name of 3 members join the group after this announcement upon your invitation in this Google Sheet. Okay, each member can invite as many as new members to maximize his or her chance of winning. For example, if you invite 12 new members, you can write your information 4 times and so on. Kind regards and by the Excellence in Endodontics group. Today we have a very, very excellent speaker, Dr. Ahmed Youssef, and he will lecture about the roadmap to manage calcification in endodontics. His biography includes Dr. Ahmed Youssef obtained his first dental degree from Mansoura University in Egypt in 2007. He worked as a general dental practitioner until 2011. With great passion and ambition, Dr. Youssef joined the endodontic residency program at the Royal Dental Institute in Egypt from 2011 to 2014. Then he obtained the MRD membership in restorative dentistry and endodontics monospecialty from the Royal College of Surgeons of Edinburgh, United Kingdom in 2015. He has been working in private dental clinics limited to endodontics since 2016 in Jeddah, Saudi Arabia. Currently, Dr. Youssef is working as an endodontic consultant in Al-Nahdi Care Clinics, Jeddah, Saudi Arabia. Dr. Youssef is passionate in sharing his excellent cases, and he is well known in publishing endodontic cases with rare and complex anatomy, which reflects his masterclass clinical skills. His cases won Post of the Week many times in the Excellence in Endodontics group, as well as other Facebook groups. Dr. Youssef also has a great passion towards sharing knowledge and experience worldwide. So, welcome, Dr. Ahmed. Let's start.
Good evening, Dr. Abdurrahman. Good evening, everyone.
Good evening, Dr. Ahmed.
I'd like to thank you for this great introduction, and also I'd like to thank Professor Ahmed Madarati for giving me this opportunity to be with you today.
Thanks so much.
Our topic today about management of calcification. The presentation today will be clinically oriented, and the theoretical part will be too minimal. So let's start. The lecture outline will talk about decision making. Is all calcified teeth need root canal treatment or no? We will talk about this in detail. We will talk about types of calcification. We will talk about management of calcification in bulb chamber. And we will talk about management of bulb canal obliteration. And finally, we will make a conclusion for management of calcification. So, firstly, is decision making. When to treat? Is all calcified teeth need treatment? You can check these 2 X-rays. The first one, we have calcified canal and we have apical lesion. And second one, we have calcified canal, but there is no apical lesion. Is these 2 teeth need root canal treatment or no? So the decision will be after seeing this paper published in International Dental Journal. There is a flow chart talking about the decision making for management of bulb canal obliteration, and the conclusion of this flow chart that we do root canal treatment only if we have symptoms or signs of apical lesion or apical bossosis. If there is no symptoms or signs of apical bossosis, we only monitor the case. But in some cases, we have discoloration. If we have discoloration, we can go for vital bleaching or partial coverage restoration. And in some minimal cases, we can do elective root canal treatment and then non-vital bleaching. So the conclusion, we do root canal treatment if there is apical bossosis or symptoms in this tooth. We will move to types of calcification. We classify classification into two parts, calcification in bulb chamber and calcification in root canal. Calcification in bulb chamber can come in two forms. First form is bulb stone, which is calcified mass forming in the bulb chamber. Second form is dentin sclerosis, which is deposition of tertiary dentin in bulb space, reducing the size of bulb chamber. And the calcification in root canal, which is bulb canal obliteration or calcific metamorphosis, which is deposition of dentin inside the canal, blocking the canal. So we will talk about bulb chamber calcification, which is bulb stone, as I mentioned before, and dentin sclerosis. First one is bulb stone. Bulb stone is yellowish and slightly transparent and glassy in appearance. So we can differentiate bulb stone from floor of bulb chamber by seeing the bulb stone is glassy in appearance and slightly transparent. What's the clinical relevance of bulb stone? Bulb stone block the access to canal orifices. So we should remove the bulb stone to can gain access to the orifices. Types of bulb stone and how to manage. We have free or lightly attached bulb stone, which can be removed easily with dental probe or ultrasonic. We can show this video to see how to remove free attached bulb stone. With ultrasonic, it moves easily. It did not take too much time. And second type of bulb stone is firmly attached bulb stone, which is slightly difficult than free bulb stone. And also it can be removed with ultrasonic, but it takes more time to remove. You can check this video. Okay, you better to remove bulb stone in one piece, as if it divided to multiple pieces, it can block the canal and can go inside the canal and block it. So better to remove it in one piece. Let's show some cases. This case came to me complaining from severe pain related to lower right 6. On X-ray, we see this bulb stone inside bulb chamber, and there is some degree of torodentism. So I removed this bulb stone with ultrasonic, as I show you before, and then I obtain access to root canals. I prepare root canals, and then I obturate the canals. Second case, for the same patient, lower right 7, with bulb stone inside the root canal and some sort of torodentism also, and strange anatomy. So when I saw this strange anatomy, I ordered CBCT and I found this C-shaped canal with 4 canals. Okay, this was previously initiated before, and there is broken file in mesiolingual canal. The dents before only find the mesiolingual canal. So after using ultrasonic, I removed the bulb stone, I obtain access to the canals, and then obturate the canals. Other case, this case referred to me by one of my friends who started access in this tooth, but he could not find the canals. So I modified the access. When you check the X-ray, you will see that the access not completely done, and you will see some calcification inside the root canal. So I modified the access. This is a bulb stone, which is yellow in color here. I removed the bulb stone with ultrasonic. I exposed 3 orifices distally and 2 orifices mesially. Then I did obturation. Another case with bulb stone removed also with ultrasonic, then obturate the canals. So we finished the first part of bulb chamber calcification, which is bulb stone. We'll move to the second part, which is dentin sclerosis, which is formation of tertiary dentin inside the bulb space. Before management of this type of calcification, we should know the pattern of calcification. Pattern of calcification in anterior teeth. In bulb chamber, the calcification will be linear, directed from coronal bulb horn toward radicular bulb, like this photo. And in radicular bulb will be circumferential all around. And in multi-rooted teeth, the calcification in bulb chamber occur on roof and floor simultaneously. Roof and floor of bulb chamber simultaneously. So the size of bulb chamber will decrease. And on radicular bulb, the calcification will be circumferential like anterior teeth. What's the clinical relevance of these words? The clinical relevance that when you face case with dentin sclerosis, there is no sensation of a drop through when you're making an access. If you feel drop through, this means you make a perforation. So the management. We'll talk about management in detail in following slides. Firstly, you should examine the radiograph before you start managing calcified canals. Best radiograph is bite wing and the parallel X-ray, as this gives information about the degree of calcification and position of bulb chamber floor and location of bulb horn and axis of the tooth. And from X-ray, you can make measurement to estimate the distance from closal surface to floor of bulb chamber, indicating how deep the handpiece can be used. So you should measure the depths of access before you go to work from X-ray. Secondly, in management of calcified cases, you should do split dam technique, at least one tooth before and one after. Why? As this gives us a clue about orientation and relation of tooth to adjacent. And we should do probing sulcus. Use periodontal probe all around the tooth to assess the shape and axis of tooth as external contour of bulb chamber corresponding to those of crown. Secondly, detect any rotation and any pronounced irregularities indicating presence of additional root. We will move to axis part, which is most important part in this section. The axis in direction should be done in direction of most occlusal bulb horn or in middle of occlusal surface, as bulb chamber located centrally on the tooth crown. Points to remember in this section that the bulb chamber never located under the marginal ridge, so don't search for the bulb chamber under the marginal ridge, and the bulb horn lie below the tip of cusps, but you should be cautious in crowned or tilted teeth. We will talk in detail about axis for anterior teeth. If we do the traditional lingual axis in calcified cases, we will end up with perforation labially. So we need to make straight line axis. This paper published in 1985 talking about straight line axis in anterior teeth. They found that traditional lingual axis allow straight line axis for only 10% of maxillary central incisors. So in calcified teeth, we should extend our axis more labially, like this diagram by Dr. Enrico Casai. This is the traditional lingual axis. To gain straight line axis to canal, you should extend axis more incisally, like this, to obtain straight line axis to canal. So for anterior teeth, you should go more incisally to obtain straight line axis. And there is a technique developed by Dr. Atonis Chaniotis for management of calcification in anterior teeth. He divides the crown of tooth from incisal edge to cement to enamel junction into 3 equal parts. And our starting point for axis will be from at the beginning of second part, which is this blue dot, okay? And our shank of our bear or ultrasonic should touch this red dot, which is incisal edge, to avoid making labial perforation, like this. This is the red, blue one and the red one. When you put your bear touching this 2 points, you will gain straight line axis here. And after gaining a catch, you can make a mark labially here to make an X-ray and check the orientation of your file inside the canal. This case, we can apply this technique on this case. This case came to me, which is previously initiated by another dentist, and he could not find the canal. I ordered a CBCT. I found that he make an axis toward labial side, which is apparent in this slide. This is axis, and the canal is here. And the canal already in CBCT appeared on the middle third. So I applied his technique. I using ultrasonic tip, and I insert it from more incisally and touching the incisal edge to avoid labial orientation. And I do X-ray. Here I found a catch. I scout the canal and negotiate it till the working length. And we will talk later about shaping strategy in this canal and all calcified canals. Now I finished the canal by applying the protocol by Dr. Atonis Chaniotis. For premolars, this paper talking about measurement of bulb chamber in maxillary premolars, they found that the distance from reference point to bulb chamber roof is 7 millimeter, and from reference point to furcation is 11 millimeter, and the length of bulb chamber is 2.5 millimeter. So when you're making an axis, put a stopper on your bear and measure it at 7 or 7.5 millimeter to find the pulp chamber. For more, let us to apply this in this canal. I make measurement on the X-ray from reference point to pulp chamber. It's about 7 millimeter as study before, and I start to making axis, and already I made an axis, and I find the canals, and then obturation of canals by applying the previous measurement. For molars, this paper also talking about measurement of pulp chamber in maxillary and mandibular molars, and the measurement was from reference point to roof pulp chamber, it is 6 millimeter, and from roof to furcation, it is 11 millimeter. So let's apply this measurement on a case. This case was failed partial pulpotomy. I applied this previous measurement on this case, and I could made an axis and find the canals and obturate the canals. After making an axis, you should examine the pulp chamber floor and seeing the dentin map. You will see that the floor is darker than wall, so you should cut in this dark area. And the cutting will be with ultrasonic. Now, to summarize the previous section about management of calcification in pulp chamber, firstly, we would make radiographic evaluation to check the degree of calcification and measure the depth of bear to make an axis, the depth from reference point to floor of pulp chamber to avoid perforation. Secondly, you should making split dam and the probing sulcus to give you orientation of the tooth regarding adjacent teeth to avoid perforation also. And axis should be with a straight line axis to canal. We should examine the color change, and we should check the dentin map in the floor of pulp chamber, and then the cutting will be with ultrasonic. Now we will move to the difficult part in the presentation, which is pulp canal obliteration. For pulp canal obliteration, you can see here the canal is completely obliterated, and here also the canal is obliterated, and here also. For management, calcification usually occur in coronal to apical direction. So in pulp canal obliteration, calcification happen from coronal side to apical side. As in this picture by Dr. Hugo Sousa, here you can check this pulp stone and pulp chamber, and this the calcified pulp coronally, and this healthy pulp apically. So calcification can occur from coronal to apical direction. But in teeth with history of trauma, calcification may occur randomly, may occur from apical direction or coronal direction. This according to best practice in endodontics. Calcified part is darker than rest of dentin. For management of pulp canal obliteration, my protocol is dividing the canal into 3 parts. First part is exposing root canal orifice. How to find the root canal orifices? By this measure that we will talk later. And after finding the orifice, probing coronal segment by this measures that we will talk also about it later, and probing apical segment by this measures. Let us to talk in detail about exposing orifices. To expose orifices, you should know the anatomic rules by Krasner and Ranko. This helps us too much in finding the orifices of the canals. This anatomic rules, first, law of centrality, which is the floor of pulp chamber always located in center of tooth at level of CEJ. Check here at level of CEJ, the pulp chamber located in center of the tooth. Second law, law of concentricity, which is walls of bulb chamber are always concentric to external surface of tooth at level of CEG. You can check here. The bulb chamber walls is the same of outer walls but smaller in size. Law of CEG: the distance from external surface of the clinical crown to wall of bulb chamber are the same throughout the circumference of the tooth at level of CEG. You can check here this law. And then law of orifice location. The orifice of root canals are always located at junction of wall and floor. So you should search for orifice at junction between wall and floor. Wall is light in color and the floor is dark in color. A junction between this 2 points, you can find the canal. Law of color change. The color of bulb chamber floor is darker than walls. For mandibular molars, we have two laws of symmetry, which is law of symmetry 1. The orifices of root canal are equidistant to virtual line passing through the tooth in mesiodistal direction in the floor of bulb chamber, and the canals also are lying on line perpendicular to this virtual line, as in this picture. So the orifices are an equidistant to virtual line passing through the mesiodistal direction and also on line perpendicular to this virtual line. Let's apply these rules on a cases. This case come to one of my colleague in the clinic to make direct filling in this tooth with class 5 carious lesion. My colleague do direct composite restoration to this tooth, and the patient come back after 2 months complaining from severe pain. So he referred the patient to me, and after making an access, I could not find the canals. And you can check here, there is the remaining of bulb stone. So I should remove the bulb stone, the remaining of bulb stone firstly. And after removing it, I examined the bulb floor and I found the first canal here, which is most probably mesiolingual canal. So I preflare the canal and this mesiolingual canal by applying the rule. This is a virtual line from mesiodistal direction, and this is a canal, the mesiolingual canal. So mesiobuccal canal should be an equidistant to this virtual line. So I search more in this area by applying this rule, and I already found the canal, and this is the virtual line, this is the mesiolingual canal, this is the mesiobuccal canal. The two canals are equidistant to this virtual line. So by applying this rule, I could find the canal here, and this is the final obturation. Second case, this case with history of root canal treatment 2 times in this tooth, and patient come with fistula related to this tooth. So I ordered a CBCT. On CBCT, I found there is a mesiolingual canal and distolingual canal. So after making an access, I found that he make obturation in mesiobuccal canal and middle mesial, but he could not find the mesiolingual canal. By applying the law of symmetry, this is a virtual line, this is the mesiobuccal canal, so the mesiolingual canal will be at equidistant from this line, so it will be here. I make troughing with ultrasonic, and then I could find it with the finder file. I could find a catch. After removing the cataverca, this is the mesiobuccal, middle mesial, mesiolingual canal. Let's go to the distal root. It is 2 canals in 1 orifice. This the cataverca. I removed it. I could find the the dystolingual canal here. I could prepare it here. Then, after removal of Gatabaca, these two canals, then the case is obturated. Let's go for another one, which is color change. After making an axis, you should check for color change in bulb chamber floor. You should have a technique to check for this color change. This technique, firstly, you should cut with ultrasonic and then irrigate and scrub with EDTA, and then make a dryness and observe. And then cut in target area you saw in bulb chamber floor. Usually we cut in the dark part. Calcification usually is darker than rest of dentin. If you calcified part is usually darker than rest of dentin, like this picture, this calcified part and this regular dentin. So the canal will be here. Cutting done with ultrasonic or Mansphere to drill in dark area. This is the canal after drilling with ultrasonic. This is the canal. We can use micro opener to detect a catch. For maxillary incisor, search for canal in labio-palatal direction in center of the tooth and look more palatal. You can differentiate between color in bulb chamber, like this photo, this dark one and this light one. If you can differentiate between this color, you can put a drop of EDTA in bulb chamber. This drop of EDTA in bulb chamber can enhance the difference in color between the regular dentin and the calcified dentin, as it gives us macroscopic view of axis cavity. So let's apply this on a case. This case come to me complaining from swelling related to lower wisdom. This tooth with a history of bulbotomy with Bulbotec. And after access, this is the dark area, so we should search in this area. I applied the technique of color change by cutting and then irrigation and scrubbing for EDTA, and then dryness and observe. When I make dryness and observe, I found a white spot here, which is dentine chips fall in the orifice. So this area might be the orifice. So I make troughing with ultrasonic, and I could find this canal with D-Finder file. Then I flare the canal, but I could not find the other canal, mesiolingual canal. So when you can differentiate between the color, make fish eye view, as I mentioned before. So I put drop of EDTA, and this enhances the difference in color. So this is the dark area. So this one is the canal. I make troughing with ultrasonic, and then I using micro opener to find a catch, and I found a catch, and this is the canal. So we find it by applying the rule of color change and fish eye view. Go to the distal root. I could find the distobuccal root, but I could not find the distolingual canal. So I put calcium hydroxide inside the orifices and bulb chamber, and I make intraoperative CBCT. When I made the CBCT, I found this the mesiobuccal canal and this might troughing here, but the mesiolingual canal is too far away more lingually. So I make more troughing lingually, and by observing the color change, I found this white spot here. This indicates that the canal in this area, and I already found the canal in this area. This is the this is the distolingual canal, and this is the final obturation. So we could find the canals by applying the rule of color change and fish eye view. Move to another case. This case come to me complaining from small swelling related to upper left 7. This tooth with history of root canal treatment by endodontists 2 years ago, and the endodontist told the patient that the distal buccal root is totally calcified and he could not negotiate the canal. So he told the patient that the tooth will be under follow-up. The tooth has endocrown. I made a CBCT to find where is the canal, and the canal is totally calcified or already patent. From CBCT, I found the canal is already patent, but only calcification in coronal part only. So I made an axis on this endocrown, and by applying the rule of color change, I found this white spot in this area, and I make troughing with ultrasonic, and I could find the canal here. This is the canal, and this is the working lens, and this is the obturation. If you could not find the canals by the previous measures, we have more measures like transillumination, which is a device placed on external surface of the tooth at level of CEJ on cervical third. The calcified dentin appear as a dark spot as the light does not pass through the calcified area due to lack of open and continuous dentinal tubules. So when apply the transillumination, the calcification will be as a dark point in bulb chamber. Another measure we can apply is bubble test by placing sodium hypochlorite in bulb chamber, and under magnification we can see bubbles emerging from remnant bulb tissue found in the orifice. So this gives us a clue about where is the location of the orifice. The last one is dyes. We can apply methylene blue in bulb chamber for 1 minute, then rinsing. Methylene blue stain the organic material, so any bulb stump will be detected as this photo. To summarize the previous section about exposing orifices, we should know the anatomical rules, and we should apply the color change rule, and usually the calcified part is darker than rest of dentin. If you can't differentiate between color, put a drop of EDTA in bulb chamber, which called fish eye view, to enhance the difference in color. If you can't find, make transillumination or dyes. It has to move to proben coronal segment. Now we exposing the orifice, but the canal is still calcified. We need to proben the coronal segment and negotiate the canal. Firstly, I prefer to do CBCT in these cases to detect the location and the orientation of the canal. CBCT will help us in detecting location and orientation of the canal and making more precise cutting with ultrasonic to avoid perforation and massive destruction of the tooth. Secondly, we should make multiple radiographs to check our cutting is in the canal or out path of the canal. This to reduce the risk of perforation, we need at least 2 radiographs at different angulation, better 3 radiographs. First one is parallel, second one was mesial shift, and third one was distal shift. The last 2 radiographs give us information concerning the relation of pair to canal lumen in buccolingual direction. If you make mesial shift, if the file move toward the cone, this means it is in lingual direction, and if it's moved away from the cone, this means it is in buccal direction. Let us to apply this in this case. This case referred to me for management of calcification in mesial root. By applying the color change rule, I could find the orifices, but the canal still calcified. So I make drilling with ultrasonic tip 8020 and 825. And after each 2 millimeter advancement, I make an X-ray with multiple shifts. As in this shift, this file is away from the path of the canal. So I made a ledge here. I precurved the file, and then I obtained the path to the canal, and then I operated, and this is the ledge that I created. We have some measures can help in breaking through coronal calcification, which is the use of short rigid instrument C plus or D finder files. Usually use short rigid instrument as this enhanced tactile sense and better control in file. If you can find any catch, you can cut the tip of file to make it active and make more apical advancement, but make it with caution to avoid perforation, and make regular X-ray to check your cutting path. Also, we can make cutting to the tip of rotary united instrument and make 0.5 millimeter apical advancement. In some cases, the difference between patent part and calcified part is small. The small area, we can cut the tip of rotary united file to make it active and make drilling with it, and we can find the canal, but you should make it with cautious also to avoid perforation. And we can use ultrasonic tips, which is the most efficient method, and the cutting should be undertaken away from forcation area. In multi-rooted teeth, when the first canal is located, you should take working radiograph for orientation as well as to determine which canal was located. As in some cases in mandibular teeth, we could find a canal and you suspected that's mesiobuccal, but in reality it's mesiolingual canal. So you should take radiograph after finding the canal. And you have a clinical tip to apply in mandibular molar, in calcified mesial root of mandibular molar. The mesial root of mandibular molar, these canals have primary distal curvature visible on radiograph and secondary curvature not visible on radiograph. This curvature lingual for buccal canals and buccal for lingual canals. So to find these canals for mesiobuccal canal, we should precurve the file and direct for mesiobuccal, direct the file toward this two lingual direction to find the canal. And in mesiolingual canal, direct precurve the file and direct in this two buccal direction you can find this canal. To apply this step, this case referred to me by dentist who could not find the mesial canals. He make lots of troughing here. By applying the previous rule, I precurve the file and in mesiobuccal canal directed to this to lingual direction, and in mesiolingual canal directed to this to lingual direction, and I could find the canals and operate this. So in mandibular molar, you should precurve the file as I told you in previous slide. Another clinical tip, you could not find the canal, you can inject radio-opaque material like calcium hydroxide in pulpit chamber on root canal. This may give you a clue about the location of canal. In this case, the dentist could not find the canal, and after injection of radio-opaque material, which is bioceramic sealer here, they give us a clue about the location of the canal. And in this case also, this is the location of the canal. Let's apply this tip on a case. This case came to me for retreatment of upper first molar. After removing of Gaberka, I in mesiobuccal and in palatal canals, and I tried to find the canal in distobuccal, but I could not find it. After removal of Gataberka, I inject calcium hydroxide and check this area. the calcium hydroxide go inside this area, this indicating the location of the canal. Then I make troughing with ultrasonic, and I could find the canals and operate this. By applying this in another case, this premolar referred to me for retreatment as there is a missed distobuccal canal. After I removing agata berca, I put calcium hydroxide, and calcium hydroxide go inside the canal. The canal is split from the mesiobuccal one, and so I could find the canal here, and this is a cone FIT X-ray, and this is the obturation. Another clinical tip for shaping protocol of this calcified cases: once you find a catch, alternate between size 8 and 10 D-Finder files or C plus files after each 1 millimeter penetration, with gentle watch winding motion with minimal vertical pressure and regular replacement of instrument before fatigue happen, and use copious irrigation. This is the most important. When you find a catch, you can make apical advancement for 1 millimeter with D-Finder 8, then remove it, copious irrigation, go to the same lens with D-Finder number 10, then repeat the same sequence till reaching the full working length. We can do it also with reciprocating handpiece, which is M4 handpiece, which create reciprocal movement 90-degree clockwise, 90-degree anti-clockwise. So the shaping strategy is first try to find the canal using ultrasonic endodontic explorer or micro opener. Once you find the canal, scout the canal in the coronal to middle third using D-Finder or C plus files. After scouting the canal to middle third, make brief layering to the canal to reduce stresses in files. By alternating between files, as I mentioned before, then glide path to working length, then shaping to working length. This shaping strategy in all calcified cases. Let's apply this shaping strategy on this case. This case referred to me for management of calcification in upper premolar. The previous dentist could not find the canal. By applying the color change, I could find the two canals, buccal and palatal canals, but the two canals are calcified. So I scout the canals. I scout the canals with D-Finder files to the middle of the canal, then brief layering the canal, then scout the canal to full working length by alternating between D-Finder files number 8 and 10, then reaching to full working length, then obturation of the canal. To apply in another case, also this case referred to me for management of calcification. The previous dentist could not find the canals. By applying the rule of color exchange and the dark area, I could find the canals, and then by applying shaping strategy I mentioned before, we could negotiate all canals and obturate the case. Another case, maxillary molar. By applying the color change, I could find the orifice, but the canal is calcified, so I make digging with ultrasonic till middle third. Then I find a catch at middle third, alternating between files to reaching the full working length, and then the canal obturated. Another case, by applying the same shaping strategy, we could make obturation to this case. Summary: for proven coronal calcification, we should do CBCT to know the orientation of the canal. Cutting should be done precisely with ultrasonic under magnification. And if you could not find the canal, inject calcium hydroxide. This gives us a clue about the location of the canal. And we should use rigid instrument to avoid breakage of an instrument and help us in make the calcification of the canals. And then we should make multiple X-rays to avoid perforation. We'll move to the last part, which is probing apical segment. Is calcification can happen in apical segment? Yes, can happen in retreatment cases with short obturation and no apical pathosis. This means the remaining bulb inside the canal make a defense mechanism and make calcification inside the canal. And these cases called file eater cases. To manage these cases, we can prevent small files like definder files and alternating between a chelator, EDTA, and sodium hypochlorite, as EDTA will act on an inorganic component of calcification and expose some collagen, and then rinsing with sodium hypochlorite can dissolve the collagen and regain the space. And we can use M4 handpiece in this cases as generate reciprocal quarter turn movement. As this is M4 handpiece. This is a movement. You can check 90 degree clockwise, 90 degree counterclockwise to make more apical advancement. Let's apply this on a case. This case referred to me for retreatment of upper premolar with short obturation and calcified canal apically. I could find a catch with definder files, and I used M4 handpiece to negotiate the canals. I alternate between file 8, 10, 12, and 15 till I reach the full working length. I thought maybe 4 or 5 boxes of definder files till could reach to this area. And then this is the obturation. Another case was apical calcification. Retreatment, this case referred for the treatment of upper 6 for fabrication of crown. In this case, short obturation, calcified canal, mesiobuccal, calcified, distobuccal, calcified battle, and missed MB2. And I make traffic to find MB2 and then find it, and then negotiate the canals with definder files by alternating between files and following the shaping strategy that I mentioned before, and then I obturate the case. When we manage calcification, we have technical complication like excessive tooth removal. This case come to one of my colleagues in the clinic, and he start access the tooth, but he could not find the canal, and he make excessive tooth removal coronally. And when the case come to me, I checked it. There's lots of tooth removal, tooth tissue removal here, and by applying the rule, anatomic rules, that the canals located a junction between floor and wall. I applying this rule and I could find the canal. Applying this rule, this the mesiobuccal canal, this is the floor and the wall, a junction. I could find this canal, and this tubercle canal I could find here a junction between wall and the floor. Not here. This the presidents make digging in the floor, but the canal a junction between wall and the floor, and this is the obturation. Another technical complication, which is perforation. This case came to me complaining from swelling related to lower right 6 with history of root canal treatment 1 year ago. But I ordered CBCT. I found a perforation in furcation, and I found these 2 canals. He make digging in the furcation in this area, and this the 2 canals. I made an access. This is a dark area, which I will search on it, but I need to remove more composite here to find the canals. After removing the composite, I could find this canal, mesiobuccal canal here, and then make flaring to canal. And by applying the rule, law of symmetry that we mentioned before, which the two canals are equidistant to virtual line passing through bulb chamber in mesiodistal direction. So the mesolingual canal will be here. So I remove composite in this area and make trafficking with ultrasonic, and I could find the canal. Now I should remove this composite in perforation, which is here. It's in perforation site, and manage the perforation. I remove the composite. This is a perforation site. This is a perforation site. I put Teflon in perforation site to protect it till I finish obturating these two canals. I obturate the canals. Then I remove the Teflon and I put MTA in the perforation. Then this is the final result. Another technical complication, which is instrument separation. During shaping the canal with files, we can separate files if we apply more pressure on the file. This case referred to me for management of calcification in mesia root. The previous dentist started retreatment, but he separate a file in mesiobuccal canal. This patient came as emergency as he have swelling related to distal root. So in first visit, I start my work in distal root only, and I put calcium hydroxide. And after 2 weeks, the patient come to me, and I obturate this canal. There is no symptoms at that time. Then I start to work on mesial canal. I start negotiation of mesiolingual canal, but during negotiation of the canal, I broke a second file in the canal here as I applied more pressure on the file. So the file is separated from me here. I left this canal, and then I moved to mesiobuccal canal, and I removed the file, and then I negotiate the canal to full working length, and then I bypass the file in mesiolingual canal that I broke, and this is the final result, final obturation. This 6-month follow-up and this 1-year follow-up. Another case referred to me for management of calcification in mesiobuccal root. The president started treatment, but he couldn't negotiate to full working length in mesiobuccal canal and could not negotiate the mesiolingual canal. And by applying color change, I could find the mesiolingual canal and I could negotiate to full working length. And then I negotiate the mesiobuccal canal to full working length, but unfortunately, I separate a file in mesiobuccal canal. Then I bypass it. Then obturation, and this 3-year follow-up check the nice complete healing of preapical lesion here in the follow-up X-ray. So our technical complication is excessive tooth removal, perforation, and instrument separation. To reduce the risk of complication, we should move to guided endodontic access. But this guided endodontic access have some limitation and disadvantage, which is the high cost, and secondly, in static guided endodontic, some limitation in molar region. There is another guided endodontic access, which is dynamic access, dynamic guided endodontics, but the disadvantage is the high cost of the device. There's lots of paper about guided endodontic access, but I did not have any experience in this field, so we will move to next slide. We'll talk about calcification and apical lesion. Is all calcified teeth has apical lesion? Nearly up to 27% of bulb canal obliteration cases have been shown to develop preapical lesion with negative reaction to sensibility test. When preapical lesion found, this means incomplete calcification. So there is pathway for microorganisms and the bacterial toxins to preapex. But in some cases, this pathway may be narrower than the tip of finest root canal instrument that we have. So in some cases, despite the presence of radiolucency, we cannot negotiate the canal to full working length. Is this meaning failure if we cannot negotiate the canal to full working length? Before answering this question, we should know the main objective of root canal treatment. The main objective of root canal treatment is to prevent or cure apical periodontitis by reducing the bacterial load to the limit that cannot initiate or sustain the disease. So our aim is to reduce bacterial load inside the canal. So when you could not negotiate to full working length, you should weigh between risk and the benefit. If more apical advancement has a high risk of perforation, so you should stop, maximize your disinfection protocol by activation of irrigation, copious irrigation, and make heating of irrigant, and then obturate the case and follow up. Like this case, the doctor could not negotiate the canal to full working length and obturate to this level, and patient came after 5 years with coronal restoration only following. He need a new coronal restoration, and X-ray you find total healing despite he could not negotiate the full working length. Another case, this case with calcified mesial root, the doctor could negotiate mesiolingual canal to full working length, but mesiobuccal canal he could not negotiate the canal to full working length. He only negotiate the coronal part and the obturate, and the healing happened. So our aim is to reduce the bacterial load by maximizing our disinfection protocol and obtaining the case, obturating the case, and follow up. So you should weigh between risk and benefit. Finally, we make a concept and conclusion. Calcification usually occur in coronal to apical direction. However, in teeth with history of trauma, calcification may occur randomly. Whenever possible, isolate the teeth mesial and distal to the calcified tooth to provide better visualization of crown form and root eminence. This will help orient the bare and long axis of the tooth without interference of rubber dam clamp. Multi-tooth isolation allow for working radiograph without clamp obstructing the view. So we in calcified cases we should use split dam technique. In multi-rooted teeth, when the first canal is located, take working radiograph for orientation as well as to determine which canal was located. Don't rush the process. Schedule enough time and always be patient. Management of these cases need too much time, so better to give morning appointment when you are still focused and take long time. It is important to know when to give up so as not to compromise the structural integrity of the tooth. Complete radiographic obliteration of bulb space does not necessarily imply an absence of bulb tissue or space clinically or microscopically. The incidence of bulb necrosis following bulb canal obliteration is up to 27%. Root canal treatment is indicated when there are clinical symptoms or radiographic findings suggestive of periapical disease. Technical complications such as fractured instrument and perforation impact adversely on treatment outcome. Using long neck bears and slow speed handpiece or preferably ultrasonic tips to penetrate deeply into canal system is recommended. Teeth with bulb canal obliteration requiring root canal treatment are challenging. Thank you.
Thanks so much, Dr. Ahmed. It was a very, very amazing presentation, filled with a lot of tips and tricks. I really love it so much. Also, a lot of comments here are praising your presentation and your tips and tricks. Really, really a very nice presentation. Thanks so much, Dr. Ahmed.
Thank you, Dr. Ahmed.
Also, it was a very systematic and to the point, with a lot of tips and tricks and a summary after each point. Very good point for your presentation. Thanks so much.
Thank you, Dr. Abdurrahman, and I hope you enjoyed the lecture.
Yeah, very much. Can we have some questions, please, Dr. Ahmed?
Okay.
So, doctor, why we search for the missed canal in the upper central incisor buccolingually, although the mesodistal width is larger than the buccolingual width?
You can put the question on the screen, please, doctor. I'm not up here.
Yeah, I already showed the comment. Can you
No.
see it? No.
It not appear to me.
Okay.
Okay.
Can you see the comment?
Okay, now it's okay.
Okay. Why we search for the missed canal in the upper central incisor buccolingually, although the mesodistal width is larger than the buccolingual width?
Usually, in upper central incisor, the canal found in labiopalatal direction, not in mesiolingual direction. The tooth is more broad in labiopalatal direction, not in mesiodistal direction. So search in the center of the tooth in labiopalatal direction and look more palatal as this tooth have inclination in crown. So look more palatal and search in labiopalatal direction as this area have broad root.
Yeah. Okay. Question by me, Dr. Ahmed. So, in your opinion, what is the most difficult situation I can find regarding calcification? The most difficult situation you can find.
Most difficult situation
Yeah.
and is to expose orifices when you have calcification in bulb chamber and occluding the orifices. The most difficult is to find orifices and to find the canals. Once you find the canal and you can once you find a catch, you can negotiate it by alternating between the file defined the file number 8 and number 10. But the most difficult part is to find the canal.
The canal orifices. Okay. 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 Another question. Do you request a CBCT scan for all cases of calcifications?
For most of difficult cases, I prefer to do CBCT scan. This gives us more information about location of canal, about number of canals, about degree of calcification. So I ordered CBCT for all calcified cases.
You prefer for the calcified canals or and bulb stones also,
No,
or just
bulb
for
stone,
the
for
calcified
bulb
canals?
stone, no. For calcified, for dentin sclerosis or bulb canal obliteration. But for
Just
bulb stone,
radicular obliterations.
For bulb
Yeah,
canal
okay.
obliteration. But for bulb stone, I didn't order CBCT.
Okay, okay. Another question. Some dentists they leave EDTA for days to facilitate canal negotiations in calcified canals. What's your opinion?
I'm not with this technique. This may soften the dentin, okay, and may lead to perforation when you negotiate the canal with files or with ultrasound. So I'm not with this technique.
Okay, I can add something, please. EDTA is a self-limiting chelating agent, self-limiting.
Okay.
As it is, it can limit its action after a period of time. So leaving it for days, I think cannot facilitate anything just for the time that it works for, about 1 minute, 2 minutes, or 5 minutes maximum.
Okay.
Okay. The chelating agent you use, Dr. Ahmed, in a gel form or a solution?
Solution.
Solution.
During the negotiation
But,
of the canal, I
yeah,
put on
yeah,
the top of the file the gel form.
yeah.
But when I use irrigation, I use it alternating between EDTA and sodium hypochlorite.
Sodium hypochlorite.
EDTA will act on inorganic part, and sodium hypochlorite will act on organic part.
Okay, okay. Dr. Professor Latifa asked, do you go for apical surgery in calcified cases?
It is an option for some cases. If you could negotiate the canal or a case with crown and well-fitting crown and the calcified tooth and the patient complaining from swelling or there is signs of radiolucency, below the root, we can make apical surgery only. This more conservative for the patient in some cases.
Just apical preparation without preparing the remaining of the canal, just apical only.
Apical preparation only.
Yeah. Okay, a lot of praising comments, Dr. Ahmed. Very amazing lecture. Really. Okay. Finally, I would like to remind our members to fill in the Google form. I left in the comments here. This Google form include the conditions of our contest. You can fill the form. You can invite 3 of your friends and join our group. And you can write their names in the Google form. And you can make 1 or more forms to increase your chance of winning our prizes. Excellent presentation, Dr. Ahmed.
Thank you.
Finally, I'd like to present this certificate to you, Dr. Ahmed, certificate of appreciation. Thanks so much, Dr. Ahmed, for your valuable scientific contribution in the 6th Online Excellence in Endodontics Conference, 5th of June to the 1st of August 2022. Thanks so much.
Thank you, Dr.
And also thanks so much our dear members. And thanks so much our sponsors, Zark, Denjoy, Dixis and Coxo, Ramo Medical, and Eteeth. And finally, thank you so much. Thanks so much. We hope you like the lecture and you get benefit from it. And in our group, you will find a lot of useful lectures here. So finally, thanks so much, Dr. Ahmed. It was a great honor for me to be with you here in your webinar. I really get a lot of benefits from your webinar and a lot of tricks in management of calcified canals. Thanks, Dr. Ahmed. So good night, everyone. Good night, Dr. Ahmed.
Good night.
Good night. Thanks so much. Bye.